All right. Well, I just want to welcome everybody to Probing the Literature, which is our new exciting joint journal club between ACEP's ultrasound section and the AEUS with SAEM. I'm Petra Duran-Gehring, and I'll be your host today. I'm the ultrasound director at the University of Florida in Jacksonville. And we have an exciting session for you today. We're going to be talking about the FAST exam. And so we're going to be discussing two articles. For the first article, we actually have the author, so we're excited about that. And then for the second article, we'll be breaking everybody up into small groups. And so we want you to be able to really kind of discuss the article, but we'll get more to that in a second. So I want to just kind of make sure we stay on schedule here. Our goal today, we have a 2-hour time slot here. So the first half is actually our journal club, where we're going to be talking about those two articles. Our second half is actually what we've termed the methods consult. So that's if you have questions, or if you have something, a research project you're working on specifically for the fellows, especially, this is your time to kind of get some feedback and get some questions answered. So hopefully we'll get everybody to tune into that as well. Again, just want to remind everybody to please mute yourself. We want you to be interactive, but while we're having the initial presentation, just please put all your questions in the chat. We'll be monitoring that as well. Please turn your cameras on because we want to see your face. We want to see who's here with us today and make this interactive. And then if you can change your name, hopefully we can do that in a moment. We'd like to know who you are. So also, are you a medical student, a resident, a fellow, faculty, and then where you're located. So what university or program you're established with. Okay, so to get things started, I'm excited that on this first article, we actually have the author. So we're going to be talking about the differences in gaze fixation location and duration between resident and fellowship sonographers interpreting a FAST exam. And so this is pretty awesome in that we have our author today, which is Colin Bell. So Dr. Bell is an assistant professor of emergency medicine at the University of Calgary, Cummings School of Medicine. He is also the POCUS clinical practice lead for ultrasound for the Canadian Association of Emergency Medicine. He was previously with the Queen's University in Kingston, Ontario, I believe, when this paper was initially published. So without much more ado, I'm going to go ahead and turn it over to Colin. I'm going to minimize this and stop sharing.
All right. Yes, so I'm Colin Bell. I'm an assistant professor in Calgary, and I did this project when I was at Queen's, and actually speaking to a lot of the fellows online here today. So this is something that I started when I was in fellowship at the Denver Health Emergency Medicine Ultrasound Fellowship. So it shows you kind of where you can go, although there are many folks who have flown a lot higher with their fellowship projects into fellowship and kind of where it can get you. So just starting out, apologies if things slow down or drop out. I'm dealing with a very unstable internet connection in Atlantic Canada. There have been kind of rolling outages for most of the day today. So hopefully y'all can hear me, and hopefully things aren't too choppy for you. So yeah, let's get started and kind of why I jumped in on this project and what the background was. One of those things that as I got more senior in my emergency medicine training and entered the fellowship, I really realized that as a POCUS person, no matter what you're educating, you're always teaching, right? And you're just teaching, and there's so much focused on education and on skill assessment. But yet, whenever you actually see a survey on barriers for emergency physicians and why they're reluctant to use point of care ultrasound in their day-to-day practice, it sounds like training and confidence is a big issue here. And so the idea is there a better way to assess? Is there a little bit of a better way to give more directed feedback? So thinking kind of back to my personal history, I have a fairly competitive athletics background, and I really remember and thought back to the amount of kind of dedicated practice I did for a particular skill. So when I was thinking about this, I was thinking, can POCUS assessment tools be used to kind of motivate and assist with dedicated practice? And then Queen's Emergency Medicine in Kingston, Ontario has a tremendous background in educational research. So talking with some colleagues there, kind of came across the COVAX procedural skill in skill acquisition in medicine. And when I kind of break it down for ultrasound, it's kind of this rapid cycle. You have this first cycle of generating the image, then you're interpreting it, you're moving your hand and modifying your image, you're generating another image, interpreting it really quickly, and this kind of rapid acquisition interpretation cycle. And so in residency, I had done a previous project using hand or probe motion analysis to try and separate the novices from intermediates and experts by their hand motion. That's a bit of a cumbersome setup, right? We had to actually attach a device to the probe and measure things, and it all kind of came, all the information came after the fact. And then I thought, well, maybe there's something else in the second part of that cycle when you're taking a look and you're interpreting the image that kind of gives away where you are. Maybe there's a hint or a tell in the image interpretation section that talks about where you lie kind of within your skill level. And I thought, are there behaviors or techniques or particular places that a machine can actually look at to see and give it away which kind of category you're in? So I thought about the gaze fixation part, and in my fellowship, I had some troubles. I did essentially the same study, but I couldn't line up the XY plane and the time plane. So this is a kind of a modification of that, a kind of bigger and better project for my fellowship one. So yeah, getting into the hypothesis is my specific research question. It's, do experts look at the same places, or fellowship trained sonographers look at the same places that regular sonographers or other emergency physicians or POCUS users use? And this kind of came out from teaching at the bedside, right? Think of how much time you spend with a learner talking about their hand positioning and where they're looking on the screen. And then think of how many times, the image is negative, right, before the learner says all that much, right? Or how many times you see a finding and it takes the learner a little bit of time to come and see it, right? There's a time difference here, and you can feel it, right? Think of when you're in the trauma bay and someone calls the FAST negative, and you think, wait a minute, their liver tip never appeared anywhere on the screen. This is kind of where this project came out of. Can I put someone into a category? And so our specific question was that they look and slightly fixate on the screen, not overall different or a different pattern, but there's either different locations or different durations. Thinking about where this went, right, with hand motion analysis, when you look at someone who's skilled, they're pretty fast at doing a FAST, right? Even though they're not necessarily rushed, they can get the image on the screen quickly and easily and navigate the patient pretty well, right? And so that's where all this stuff kind of came from. And so then looking into different ways to quantify this relationship, and that's where the gaze fixation tracking came from. So how do I actually quantify how long someone looks in a particular space and where they're looking? So we thought we'd find some differences, and this was kind of a proof of concept study to see if we could actually find any differences. So our study design for methods, we had a cross-sectional study. So we just took one point in time, one slice of residents and of staff as a convenience sample, and we had them in kind of two groups. So the first group was majority residents, actually all residents, and all of them had completed their ACEP or the CAPE, Canadian Association of Emergency Medicine, residency milestones for point-of-care ultrasound. They had all got, I think they'd all got above the ACEP number, and the Canadian numbers are just slightly different. It's 200 instead of 150, but they'd all kind of achieved that milestone. And then we had fellows, right, or people who had completed a fellowship as our second group. And we just said, slice one point at a time. Everybody sat down in front of a computer and viewed the same ultrasound, and then had to tell whether or not there was free fluid and in which quadrant where it was. And so everybody knew it was a negative FAST. It was a negative scan on the image, but we did find some interesting differences. So the eye data was analyzed using the Wilcoxon rank sum test. And then because we were looking at so many different spots, right? Think of where you look, the liver tip, the spinal-renal interface, right? Right at the diaphragm level, right? There are so many different places. Our Bonferroni correction was 0.0034. So we had to do a little bit of statistical magic and did a Pearson's correlation as well to assess for association. So just taking a look, what did we get, right? Well, out of 24 residents, because one person, we didn't get great, we had to eliminate one participant because they leaned backwards out of kind of the area where the vision tracker would track. So we had to eliminate one person. We had 24 residents and 8 fellowship trained sonographers. And what we found was that when we identified every region of interest or the areas in a FAST exam where you typically look, almost half the residents, just less than half the residents missed one place, right, within a complete FAST exam. Whereas every fellowship trained sonographer looked in every area we would expect them to. And so the question becomes, if you don't really look in the right areas, how can you expect someone to completely interpret the FAST exam, right? There's the possibility that in any particular area, there could be a finding that makes the study positive from negative. We thought, and I was initially expecting to find, kind of based on the speed with which expert sonographers move their hands, and which in a previous study was quicker, I thought that I'd get different time for how long people looked at particular areas. However, when corrected for multiple assessments, really there was only one space where there was a difference between resident and fellowship trained sonographers, and that was in the left upper quadrant at specifically the splenorenal interface. So right actually in kind of the deep recess of the spleen and the kidney, which is kind of an interesting finding we'll talk on in the discussion. So as far as the discussion goes, the underlying assumption is that the training of these of Canada and the United States resident sonographers is equivalent, right? Otherwise, this isn't generalizable well, frankly, to most people on this call. I think you're going to have to take my word for it for those of you who have never worked in Canada, but this is it's essentially the same training process. When I went to Denver Health for my fellowship and was participating in training residents in ultrasound and coaching them, the process was almost exactly the same as what I encountered as a Canadian emergency medicine resident at Queen's, the program that I came out of. And I know that at many other sites in Canada, the training programs have a similar organization, and there's a few folks in Canada leading emergency medicine that have done trainings pretty similar, right? What we found was pretty interesting that there was at least there's a significant portion of residents that did not look in a particular area when interpreting a FAST exam. And when you kind of boil down if you missed kind of one spot, you probably missed a few, but only 14 or 16 of the 24 residents did actually look at every area in each exam. So a huge portion were missing at least one spot. And if you think about it, right, that's an area where free fluid could be hiding. That totally changes the test and whether or not it's positive or negative, right? And that could lead to you getting caught with your pants down at the CT scanner when the patient crumps, right? It can make you look bad when you're telling the trauma surgeon that the FAST is negative and then the CT comes back with it being positive, right? And you kind of know this intuitively when you teach at the bedside that there are folks that aren't looking in every spot, right? Think of the number of times you start to point at the screen, right? But the difference between that is when you're pointing at the screen, you tip somebody off to kind of where it might be. So the idea of doing this in the background, I think, is really important, because by the time you start to point, right, you've tipped off the learner to look in a particular place, and their brain can interpret the image very quickly, right? Once you've tipped them off to the fact that they're maybe missing something, right? And they can tell you about it before you can even reach that point on the screen. So I think it's really interesting. I think it has a lot of downstream implications for how we kind of test and teach FAST. And when we think about it, right, like when I'm creating an ultrasound course, the people that I'm recruiting are either negative, right, or they're actually gross positives. Like I'm trying to find peritoneal dialysis patients that have a bunch of fluid in their belly so that they can look, right? And what we really worry about in the trauma bay is actually those subtle positives, right? The people who haven't quite crumped, but have the potential to crump in the near future, right? And maybe we should be thinking about bringing blood products to the CT scanner or getting other things organized. The other thing that kind of came out of this that was particularly interesting was the behavior, right? And I think that most of us on the call know that not all quadrants in the FAST are created equal, that they have different sensitivities and specificities, and your chance of finding pathology in a particular quadrant, right? I think the reason why most of us start with the right upper quadrant is different from the left upper quadrant, and even different regions within the right upper quadrant, right? And so we found that particularly interesting looking at it. Now, the timing when corrected for multiple associations did not turn out to be statistically significant, but hold on one second. Sorry, I'm occupied. I can't come to the door. So the interesting area, I'm on vacation. The interesting part was that not all areas are created equal, and subsequently that trainees are really investing a tremendous amount of time, say, in the left upper quadrant and treating it as equal to the right, but the right upper quadrant is far more sensitive for a FAST, whereas any positive finding is fairly specific, and the left upper quadrant is maybe a bit more specific. So then what's kind of our next steps? Well, I think that needs to be kind of shown again, right? So it's one of those things where there's always need for more research, but did I just pick up a finding that's a little bit different based on the way that I looked at, right? Did we just look at a bunch of people who are really used to looking at somebody else's studies, right? Somebody else's videos during video review? Or did we pick up something that's really there? So I think this needs to be looked at in a couple of different ways, again, and probably with some different studies. And then I think it has some implications about how we kind of employ and train people to evaluate, right? And so typically right now, when we're evaluating the interpretation of an image, we're interpreting we're looking at kind of the binary yes or no. Do they get the answer the same as we expect, right? And we actually have to go kind of one step before and start training people and assessing the methods, right? Did they look everywhere they needed to look to before calling a study negative, right? Did they actually do a complete evaluation and a complete process? So I think the take-home points are that we're teaching image generation. We overwhelmingly teach image generation, right? And we actually relatively under-assess or neglect image interpretation. It's a far harder thing to evaluate. And so when we ask for the sum, right, of is it positive or negative, right, we're not actually able to really easily evaluate where they looked, right? And it really kind of emphasizes putting in kind of subtle positives or pathology in different locations, right? In trying to train people to look in all different spots. So we need to adapt both the training and the evaluation processes. We probably need to make them more robust and regular as well. So you're getting assessed more often, right? And assessing the process rather than the absolute result. And then I think when you kind of step one step further, EM is a specialty made up of a lot of different things, right? It's a specialty of other specialties. And we do a lot of infrequent and related, but not necessarily repeated procedures, right? If you think about any surgical specialty, they do 4 or 5 of the same thing on the same day, over and over and over again, right? And so you can kind of think of a future where you get kind of some digital automated feedback. You go into a skills lab for a day, do a bunch of different procedures, and a machine tells you kind of where you are, where you're going wrong, what you could be doing better, and provides you with some dedicated feedback. And that, for some people, may be a lot easier to accept than it is to accept someone telling me how to intubate somebody as an emergency physician, right? Like, I think I know this, but maybe I'm not the best. Maybe there are things that I could do differently. Maybe there's a thing that I need to deliberately practice. And I'm not talking about just difficult intubations, but perhaps it's a way that I use the bougie, right? I need to kind of figure out exactly what I need to do differently. So that's kind of where I'm at from this paper, although I think it can be interpreted in a few different ways. Lessons learned, things I might do in retrospect. I think if I was doing this over again, so I was focused, because my first fellowship project didn't quite line up as well. I was focused on getting it done. And I think what I would really like to do was incorporate a way that people could interact with this video. So in the way that we may do more naturally in video review. So when it's negative, look at all the places and then move on, right? Rather than have it sit until the end of the quadrant was played, because that may have biased the results a little bit. I would like to have taken the learners and compared them to themselves at the end of the year, right? Or kind of a year later, and see if the same learners had the same behaviors, right? Or did people modify over the year? Did they get better? Did they change their behavior? And then I think going a step beyond that, a mixed methods evaluation may have been a good thing to include here. And it's interesting because in other gaze fixation literature, it really shows that athletes or even experts in other realms are not entirely aware of where they're looking or why they're looking in particular places. And then the step beyond this is to actually get the operator to generate their own images and then assess their interpretation, right? So actually have someone generate their own image and then see where they're looking to. So as far as kind of lessons learned, I think there's a lot to be kind of improved upon in this study, and hopefully I'll get around to doing the next one.
This is a really, really interesting study, Colin. Thank you so much for talking with us about this. I think that I found this really interesting, especially because I'm always trying to figure out how my residents are learning or my fellows are learning. And I thought it was interesting how you actually broke down all the different levels as far as EM1 versus EM2 versus EM3. This was done at the end of the year though, right? Towards the end.
This was, I believe, I'm trying to remember exactly when this was done actually, now that I think about it. I think it was done partway through the year. So I don't think it wasn't, we wanted to separate it. So it wasn't done right after kind of a bolus of training or when we do our kind of larger ultrasound courses. I think this was done halfway through the year at an annual simulation day.
Okay, I think that's something that most of us who are, in education are really interested in, how, people learn over time and how much are they retaining. So this is a really interesting tidbit here. And I was wondering, did you kind of look at, I know you broke down as far as the resident level. Did you guys find that the residents who missed those specific 5 views were, interns versus senior level residents?
So we found that they were actually all over the place. So it wasn't, I mean, when you're teaching ultrasound and when you've taught it for long enough, there are people who get it and there are people who struggle. And then within the population of people who struggle, there are people who struggle with their confidence in the image interpretation, and there are people who struggle for other reasons. And I found that the people who I thought got it looked at all the spots, but then, there was kind of mixed throughout. So the residents who hadn't looked at all the different areas had still kind of met their criteria, right? They had still kind of ticked the box of their residency requirements for ultrasound. And yet, and that happens to a lot of people. And you see these folks as staff or even further along in residency, right? They're still struggling with it, even though they've ticked the box. And so it really is a critique of our teaching and assessment processes. And that there are ways that we can do this better, right? The problem is that they're hard, right? And they require a lot of technology, or they require a frame, us changing our frame of mind, right? And so it really kind of goes to show, hey, you need to do this a lot and over and over and over again. And perhaps the way that we train people where it's convenient for us, or at least many places train people with kind of a big bolus dose at the front and then kind of once or twice a year repeating it. Maybe we need to do this a lot more often in much smaller chunks, right? And then really focus on that interpretation component. That's a hard thing to test.
It's definitely, and I think most people are, probably doing sort of OSCE or a, SDOT type of assessment, and that's so time consuming. So what you were doing is actually quite fascinating for places like my shop, where there's only really 2 ultrasound faculty and 15 residents per class. So do you think that there would potentially be any type of AI algorithm on some of these newer ultrasound handheld machines perhaps that could kind of interpret or kind of assess people's use of ultrasound the way that you did?
So I think that stuff probably exists with some hand motion. I think it's a little bit harder when you're talking about gaze and where someone is looking on the screen. I'm not sure that our iPhone cameras are good enough at tracking exactly where we're looking on the screen from various depths. But I do think that this is the, it's so much when we're coaching ultrasound, right? No matter what assessment tool you're using to assess, right? You ultimately what we're stuck with kind of at the end of the day, whether it's multiple choice or when you're looking at the screen, right, is I'm interpreting the image that they've done and then I'm asking the resident a question about it, right? And so there's a little bit of a tip there, and I'm interpreting what they've seen first. And I think it really kind of goes back kind of one level up, and you have to say, well, I really need to do a lot more work on image interpretation, right? I mean, we spend so much time on generation, and then just assume that interpretation follows. But we're the ones, the reason why we've gravitated to ultrasound is because we're the ones that get it, and for the folks that struggle with it a little bit more because of a different mindset or different skill set or background or for whatever reason, right? That part is it's a lot more challenging to assess. And when we assess it at present, we're assessing kind of the overall results rather than how you go about getting there, right? And that's where we're going to find places for people to improve, right? Maybe you're not confident in employing this clinically because actually you don't know you're missing the space, the right upper quadrant above the diaphragm look for hemothorax, right? Or you intuitively know it, but no one's told you because I can't look at where you're looking as a learner.
This is such a great tool that potentially could be useful for all of us. Well, does anybody have any questions for Dr. Bell?
No, I can't, I'm doing this on my cell phone because my internet connection is pretty unstable here. So I actually can't see the chat and see the video at the same time.
I was trying to see if anyone had placed anything in the chat. I think there's been some comments about how they really liked how you worked through the process and how you actually came to your research question, which I think is really important for our fellows who are on the call. To kind of come up with something that's useful or that you're passionate about and be able to move forward and kind of work through that process. It looks like Mike Boniface, you have a question?
Yeah, thanks, Petra. So Colin, awesome work. I mean, congratulations. It's challenging doing educational research in general, and especially ultrasound educational research is even more difficult to find something novel because it's so saturated. And boy, this is novel. I mean, this is really cool stuff. Future directions for this, have you thought about there are devices that measure eye tracking in like glasses or goggles, and that way you could actually bring this same question to the bedside, to a real world setting, which I imagine is going to significantly change both the time of interpretation and your accuracy.
So it's hilarious that you asked that. That's actually where I went wrong in the first step in my fellowship. So I don't know if John's on the call or anybody else from Denver Health, but the problem there was that I couldn't line up the XY plane for everybody. So I couldn't quite standardize it as much as I think that that's where this is going to go, right? In the future, I think that there will be these, immersive environments where there'll be these environments where you can go and the two, the quadrant that I'm on, right, and the grid that the wall is on, or the screen, right, those will be able to line up. I couldn't line those up as well as I would have liked to get an accurate analysis. And then I couldn't line up the time variable because people started at slightly different times. So the glasses are a great idea for real world stuff. And I think they're a great idea for especially mixed methods assessments of this. But when you're looking to actually quantify the particular pixel or region, it's a little bit more challenging. And that's just kind of a background thing with the software. I think eventually that problem will be solved.
Excellent. Great thought, Mike. Anybody else have questions right now or anything else they'd like to say? Nothing? All right. Well, I really, really enjoyed your article, Colin, and thank you so much for coming today to help us out with this. And if anybody has any other questions, we can always shoot them out to you via email. And then what we're going to do is we're going to slowly kind of wind down on this article, and we're going to break into our small groups. I'm going to quickly share my screen one more time just so we kind of can go through what our next article is, and then we will move on.
And just so you know, so my name's Dan Mersch. I'm actually just kind of controlling the Zoom end of things. The Zoom rooms are all ready for participants, and as soon as I am notified, I will open up the rooms.
Awesome. Okay. Yes, thank you. We have an amazing team who's been working through this process. And so thank you to all of our crew here. We'll hit them up in a moment. So our next article is going to be the focus assessment with sonography and trauma. In hypotensive injured patients frequently fails to identify the need for laparotomy. And this is a multi-institutional pragmatic study. So we're going to break into groups. And so we've got, looks like about 14 groups since we have, well, right now we have 105 people on the call. Our group leaders are a lot of people who are been helping us out with this, and we really appreciate them. So what we're going to do is I'm going to let Dan break into everybody into small groups. We're going to discuss the article, and then I've just asked that you in your group think of a question or something interesting that you found about the article to bring back to our group when we kind of all come together after that time period.
Groups are open.
Or, I mean, we talked a lot about just the limitation of not knowing exactly who's doing the FAST exam, and that, you know, when we're trying to apply the results and the sensitivity and specificity, you know, to our practice, it's difficult not knowing, you know, whether there's going to be significant differences between, you know, me as a PGR fellow or as a resident versus an attending.
That's a great point. It really kind of goes back to just, you know, the first article, right? And that there's a slight difference between what a fellow might do who is more experienced from a resident. So great point. Let's see who else. How about, let's see who else I can see on here. Jason Arthur, your group, what did you find? Who's in your group who can talk to us?
Oh, where's Amy or Dr. Coney Bear? One of y'all want to chime in, or y'all want me to do it?
Sure, I can talk. So I'll let you off the hook this time. So we talked a lot about the limitations of the article as well, and like Josh's group, we also talked about a lot of unknowns that this paper presents, and it's kind of interesting that this paper took data from an existing database, and so it was a lot of unknowns. And what was also remarkable was that all of the authors, there were no emergency medicine representation in the authorship group, and the corresponding author actually belonged to the Department of Pharmacy, which I don't think I had previously read an ultrasound article that was from a pharmacy before, but we kind of concluded that yes, like maybe the FAST exam was like really built for specificity, and it's not necessarily built for sensitivity, but we often like use it for sensitivity, and maybe that is a misuse of the FAST exam in itself. And the beauty of emergency ultrasound in general is that it's so convenient. It's at bedside. It's something that we can reassess the patient with as dynamic hemodynamics change, and it's a dynamic tool that we're able to use. And so a static picture may not be able to tell us the true status of the patient, and it's something that we just have to keep in mind.
Awesome. Yeah, exactly. Great point. Great point. Let's see. I see Michelle Mendoza. Do you have a group? Can you tell somebody from your group to give us their point? Or if you're going to
Sure. I think my favorite quote from the discussion had to come from our Metro Health faculty member, Dr. Is it Cabot or Cabot? I just want you to reiterate your troponin quote there. You can be still on.
Yeah, so we were talking about just it really the results really have to do with kind of the question that you're trying to answer. And so to me, this reads a lot like rewriting the paper saying, does the troponin test indicate the need for cardiology consult? Because really they're just saying, does a positive FAST indicate the need for an XLAP? And I mean, it's really not what the FAST is designed to look for, because there's so many different ways of assessing the patient and obviously managing the patient depending on what's going on. And what the giveaway for me was like a true positive FAST was one where the FAST was positive and they got an XLAP, versus a true positive or false positive FAST was it was positive and they didn't get the XLAP, and that's just not what the FAST does.
Excellent point. Excellent point. A couple more here. What about Erica St. James? What did your group come up with? You want to have somebody speak for that for your group?
Sure, if either Dr. Elkin or Dr. Risby wouldn't mind giving us a point. Sorry to put you on the spot.
I guess we talked about the fact that, yes, like if the paper had broken down on the different levels of training, that what I know that there were like multiple providers that were included, that their scans were included, but if we just like say what level of training they were at, that would be more helpful, especially, doing an ultrasound fellowship and going through that. I would hope to, I would like to see that I'm getting better, like have better sensitivity and specificity for FAST. And the other thing was also if they went through all the different, what were the sites that we missed? Essentially, like if there were any negative FAST that had more, were there more retroperitoneal bleeds when they had more negative FASTs, or or more solid, or like more bowel injuries and stuff like that. That would be really helpful too, to see like where exactly the I guess the limitation of FAST lies.
We also talked a little bit about the lack of quality assessment of the images. So knowing, are these even good quality images, or are these limited images for which they're making these determinations? So just again, sort of lack of information on the secondary analysis.
Yeah, I think that's always the key point, is like who's making that determination if it's negative or not. In our shop, like the resident is not allowed to say it's the FAST is negative without an attending looking over their shoulder because of that same exact fact. So I think that you're absolutely right on that point. Let's see, who else can we call on? Mike Boniface, what did your group come up with?
Yeah, well, maybe Dr. Al-Shabani is there. I'll have you give a brief assessment. The one thing that I will say, it's a journal club, right? So inherently, it's like a morbidity mortality for authors, right? So we're here to pick it apart and criticize it and say why we don't like it. But now, one thing that resonated for me is that the authors have a point here, in that we do use the FAST examination for a lot of patients that aren't sick and might not even need it, right? And so when we're doing that and we bump up our true negatives that much as far as the total proportion of patients we perform it on, that is going to inflate the specificity. So they do have a point with regard to that. But Dr. Al-Shabani, Lubna from Brown, do you want to talk about some of the other salient points our group discussed?
Sure. I guess also they should mention that we should like repeat the ultrasound, the FAST exam, like each 10 minutes, 15 minutes, just to make sure that we have a serial exam and to know what happened exactly to the patient. Is he's if he's developing any fluids now, or to know exactly what happened. Also, I guess they should put all the patient in the study. They just put the 318. I'm not sure, they didn't include all the patient to do FAST exam with. I think this is the two points we discussed. I'm not sure if anything else.
No, that's great. The what we brought up about the utility of serial FAST examinations, I think would be a really interesting question here as well. If you look at the patients they identified as having a negative FAST examination that ultimately went for a therapeutic lap, particularly the blunt patients, the intercordial range for when they went to the OR was over 3 hours afterwards. So a lot can happen in that time.
Yeah, we actually were talking about the exact same point, is that the time to the OR on that FAST negative group was so much higher than on the FAST positive group. And so, a lot of things can happen in that time span. And so when was the FAST done within that continuum was an interesting point. I agree. Let's see, Jared, do you want to talk about what our group discussed? So I think you had some really nice points as well.
Yeah, I think we've hit most of them. I think the training was a huge thing that we discussed in our group. It's kind of ludicrous that they looked at penetrating trauma as part of a FAST because that's just not an indication for it. And then the repeat, I think everybody's hit that a repeat is done. And then the timing to the OR is just really kind of ridiculous that within 6 hours, and not to record when that FAST was done compared to that. I mean, remembering that we're looking for hemoperitoneum and not solid organ injury and what that may represent. So I think those were the ones we hit on. I hope I didn't miss anything else.
Sounds good. All right. Let's see. We're finished up here. Tara, Tara Smith, what did your group come up with? Any other salient points?
I think most of the ones we discussed have been talked about. Just another thing that we were going to add was the generalizability of the study. They looked at a very specific population, hypotensive trauma patients that required blood products, and then had an XLAP. So it's a very specific population that can't be generalized to all of the trauma patients we see. And then we talked about the FAST exams being categorized as positive versus negative, and including this intermediate result in the negative group, as opposed to having a positive, intermediate / equivocal group and a negative group, and whether or not a repeat FAST exam would be beneficial in terms of those intermediate results.
Maybe we should even just be calling it either positive or equivocal. There is no such thing as a negative FAST exam.
Yeah.
Great point. All right.
Dr. Shannon, you're starting to sound like a radiologist.
On a fence, wearing
Not until he
flip-flops,
asks for
eating a
clinical
waffle
correlation.
under a hedge. Yeah, all that.
All right. Well, I think since we're right at a little bit after 4 o'clock, since we started a little bit late, the last thing I just kind of want to hit on, I'm just going to quickly share my screen one more last time. Again, I just want to say thank you to all of our small groups instructors. I didn't include our team who actually helped out as well. So I apologize for not putting you guys on there from our planning team, since we had so many people who registered. This is awesome. And then just to give us a plug for next month, we are doing DVT ultrasound. So stay tuned as to what 2 exciting topics or 2 exciting papers that Dan is going to pick, but we are going to be talking about DVT next month. And so the other thing I want to just quickly mention is that anyone who is interested or would love to be a small group instructor, we're going to start keeping a list. And so this month we hit a lot of people from the Southeast, and we'd really like to incorporate everybody from across the country. So if you want to be a small group instructor, just feel free to email me and I'll get you put on the list. Even if you can't do it this month, we have a curriculum that extends for the entire academic year. So anytime you want to help out, we would love to have you.